Welcome to today's Explainer. Think of me as your senior medical examiner today because we are doing a strict, uncompromising clinical audit. We're going to dissect the most devastating diagnostic execution gaps in pediatric infectious diseases. Look, in high-stakes clinical environments, relying on surface-level clinical noise will lead to irreversible morbidity. So today, we are stripping away that noise, and we're going to build a completely fail-proof mental model. Here's our docket for today's proceedings. We are moving fast, zero filler, covering 4 critical modules. 1. The intracranial architecture. 2. Reconstituting the pediatric limb. 3. The coronary threat matrix. And 4. We're doing a mandatory validation drill. Let's begin.
All right, let's dive straight into Module 1, the intracranial architecture.
When evaluating congenital infections, novice clinicians often fall into what we call the 50-50 dilemma. They completely confuse congenital CMV with toxoplasmosis. So let me deliver an absolute executional pearl right now to break that trap. 90%. Up to 90% of newborns with congenital CMV are entirely asymptomatic at birth. Seriously, the single most frequent execution gap on the boards and in the clinic is assuming a normal physical exam excludes CMV. It does not. If maternal seroconversion is documented, waiting around for symptoms is a trap, and neonatal PCR must be obtained within the first 3 weeks of life. Now, let's bring the symptomatic infants to the judge's bench. You have an infant presenting with microcephaly, chorioretinitis, and intrauterine growth restriction. The clinical lawyer looks at this and concludes CMV and toxoplasmosis are identical here. Why? Because they get distracted by clinical noise, things like hepatosplenomegaly, or that classic blueberry muffin rash. But listen, that rash is literally just dermal erythropoiesis, which occurs in both profiles. We have to strip away this noise to find the true signal. We demand a strict audit of the brain's actual spatial organization.
This right here is exactly where the tipping point lies. Notice the strictly periventricular enhancement. These calcifications literally hug the margins of the lateral ventricles, resulting from subependymal necrosis. That is the distinct, undeniable signature of CMV. Toxoplasmosis, conversely, scatters diffuse parenchymal calcifications completely throughout the cortex and the basal ganglia. Generalized scatter versus a periventricular cluster. Do not confuse the two. Beyond the spatial organization of those calcifications, there is one highly specific clinical signal: sensory neural hearing loss. Discharging a suspected CMV infant without organizing an immediate baseline audiogram is a catastrophic failure of care. Why? Because delaying targeted antiviral therapy, specifically valganciclovir, directly worsens their progressive hearing deterioration. We use the audiometry and the antivirals to arrest that trajectory before it's too late.
Moving right along to Module 2, Reconstituting the Pediatric Limb.
We're shifting focus to the acute pediatric hip, an area where diagnostic boundaries dictate the difference between a simple, self-resolving limp and permanent joint destruction. So, is it transient synovitis, or is it a destructive septic arthritis? I'll challenge you to identify the true discriminator here. With an acutely painful joint, there is absolutely no single vital sign or physical exam maneuver that can perfectly separate these two inflammatory states. How do we cross this selection boundary without making a critical error?
Well, we solve it by objectifying our decision-making. The Kocher criteria scoring matrix acts as our severity invasiveness scale. Each positive metric adds cumulative probability that you're looking at a pyogenic septic joint. If you have a child who is completely non-weight-bearing, rocking a fever over 38.5 Celsius, a peripheral white blood cell count over 12,000, and an ESR over 40, boom, that is 4 positive metrics. A score like that absolutely demands an invasive response. You do not watch and wait when the matrix lights up like that. Notice the strict sequence of this protocol. Step 1, immediate ultrasound-guided joint aspiration. Step 2, target organism identification, which is frequently Staph aureus. Step 3, empiric IV antibiotics like ceftriaxone and vancomycin. Let me hammer home the fatal mistake here. It's initiating empiric intravenous antibiotics before securing that joint fluid aspirate. If you pre-treat a sterile field, you sterilize the culture. You permanently lose the ability to identify the organism, basically flying blind, while the joint is destroyed. Aspiration always precedes antibiotics. Let's hit Module 3, the coronary threat matrix. We are evaluating prolonged pediatric pyrexia, persistent fever.
I want you to visually force yourself to contrast these two presentations. On one side, we have exudative pharyngitis, typical of scarlet fever. On the other side, the classic strawberry tongue, an indicator of Kawasaki disease. Both kids have a red mouth, fever, and a rash, but the pathomechanisms are entirely different. One is an exotoxin-mediated bacterial reaction. The other is a severe, sterile presentation targeting the vasculature. This lays out the tipping point perfectly. Scarlet fever stems from a distinct microbiological source, Group A Streptococcus. It yields positive cultures and a sandpaper texture rash that typically spares the face. Kawasaki disease, however, is a sterile systemic vasculitis. It's entirely independent of pharyngeal exudates. So what's the absolute defining boundary for Kawasaki? A mandatory 5 days of fever paired with mucocutaneous indicators like unilateral adenopathy and extremity swelling. And here is the timeline dictating our therapeutic window. Days 1 through 5 establish the fever threshold for Kawasaki, but the hard deadline is day 10. The really dangerous trap is withholding intravenous immunoglobulin, IVIG, and high-dose aspirin because you are waiting to see if the fever resolves, or maybe you misdiagnosed it. Withholding this therapy past day 10 guarantees an unacceptable risk of coronary artery aneurysm formation. Therapy must be delivered within this 10-day critical window to arrest that vascular destruction. Finally, Module 4, the mandatory validation drill. All right, you have the framework. Now I'm putting you on the witness stand to prove you can synthesize these boundaries under pressure. Vignette 1. A newborn is evaluated for microcephaly. Head CT demonstrates a cluster of calcifications confined strictly to the margins of the lateral ventricles. An audiogram confirms bilateral sensory neural hearing loss. Based on that distinct spatial map hugging the ventricles and the hearing loss signal, you should immediately and confidently identify the congenital CMV profile. Vignette 2. A 4-year-old male refuses to bear weight on his right leg. He is febrile to 39.1 degrees Celsius. Laboratories demonstrate a peripheral white blood cell count of 14,500 and an ESR of 55. I demand that you mentally calculate the kosher criteria metrics here. Let's look at it. Non-weight bearing, fever over 38.5, WBC over 12,000, ESR over 40, that is 4 out of 4 metrics. This is a pyogenic septic joint until proven otherwise, necessitating an immediate joint aspiration. Before we wrap up, let's trace this real-world chronology of congenital CMV one more time. Maternal seroconversion happens silently first. Then comes the critical window, neonatal PCR within the first 3 weeks. If you missed that because the newborn exam was normal, the pathogen follows a stealth trajectory. The periventricular calcifications form, and it silently progresses to late-onset hearing loss. Relying on a benign newborn screening exam completely misses the stealth trajectory of this pathogen. We're going to end this audit with a final, uncompromising question you must ask yourself in every single clinical encounter. What is this single, absolute next step to avert irreversible morbidity? Is it an audiogram, a joint aspiration before antibiotics, an IVIG infusion before day 10? Think about it. If a normal physical exam misses 90% of a devastating pathogen like CMV, ask yourself how many other normal exams are actually just silent countdowns to permanent damage. Commit to the correct execution protocol before you ever face these traps. Lock these frameworks in, and I'll see you in the next explainer.